Good afternoon, everyone. I am Colonel Dr. P.K. Thakur, Professor in Radiation Oncology, Department of Lymph. In the outset, I want to thank the Principal of APJ Abdul Kalam College of Physiotherapy to have involved Department of Oncology in the overall teaching process of physiotherapists. The topic given to me is a very complex topic, very vast topic, but it is worthwhile. Head and neck cancers and physiotherapy. Head and neck cancer, this term is a comprehensive term, denotes of all the cancers arising from the upper aerodigestive tract. What is upper aerodigestive tract? It includes the lips, the oral cavity, oropharynx, the sinuses, the larynx, the hypopharynx, and the salivary glands. It does not include the cancers arising from, for example, the brain or the eyes or even the thyroid gland. Why is it so? Is dependent upon the fact that head and neck cancers are arising from a surface epithelium lining all these genital areas and getting exposed to the tobacco smoke especially and other environmental factors which cause cancer. The major subsides of the head neck cancer regions is larynx, as depicted in this picture. You can see this is the anatomical illustration. It starts from the hyoid bone down to the second ring of the tracheal cartilage. This is the thyroid gland, this is the thyroid cartilage. This is the coronal picture, which has got three subdivisions shown of the larynx. The larynx proper, where the speech is produced, which is called glottis. The superior portion called supraglottis, and the inferior to the glottis called the subglottis. Thus, the larynx is subdivided into three parts. Second most important part now is that all these cancers, they arise from the surface epithelium. The lining of all these regions is called epithelium. They vary from part to part, like most of the tissue lining of the oral mucosa is squamous epithelium. The epithelium of the nasopharynx is ciliated, but all these epithelia lining the head and neck cancer areas, they are built up of multiple layers of cells, the basal layer of which is dividing and pushing upwards and getting modified and ultimately shed out. These 4 to 10 layered cells called the epithelium, the continuous lining all over the aerodigestive tract. And most of this surface epithelium is squamous, hence squamous cell carcinoma is the most important type of cancer in the head and neck area. There are many other subtypes of squamous cell cancers, which is called lymphoepithelioma, spindle cell carcinoma, verrucous carcinoma, undifferentiated carcinoma. We need not go into the details of the histopathological types of cancers, but only most importantly is to understand that the cancer process starts in this surface epithelium because they are the first fighting mechanism with the environmental pollutants and assailant like the tobacco smoke, like the other pollutants like alcohol, etc. Second, more than 90% of head and neck cancers, as I said, is squamous cell carcinoma in origin. But there are other varieties also. In 10%, they may arise from the glands which are present in this region, or the lymph cells which are present in this tissue, or from the mesenchymal tissues. So there may be adenocarcinomas, lymphomas, sarcomas, or neuroendocrine tumors. So this cancerous process, which is starting in the surface epithelium, is it immediate? No. It takes years together for a normal epithelium to get converted into cancer. In this slide, this is the histopathological section of this clinical conditions depicted in the upper panel. Here, if we notice, this is the normal surface epithelium, and this is the cancer. In between, there is a progression from hyperkeratosis, that is, decrease in the number of shed cells and keratin follicles. As we said that the basal layer divides and pushes upwards and sheds ultimately. This is hyperkeratosis. When this process continues in the presence of continuous assailants by the pollutants or the etiological agents like tobacco, then dysplasia sets in. Dysplasia means abnormal cells which have got nuclear atypia. And dysplasia is also increasing in intensity from grade 1 to grade 3. And thereafter, there is a frank conversion into cancerous cells. So what is the difference between dysplasia and cancer? Dysplasia can be reversed back to normal epithelium if the etiological factors. And this is happening because of continuous accumulation of mutation over a period of many years. And once dysplasia converts into cancer, the basement membrane on which the epithelia are founded, that is broken, and the cancerous cells, they invade deeper into tissues. So this is an important slide, and try to understand that cancer is a chronic process of assault by the etiological factors, that there is a interim period of dysplasia. There may be multiple factors responsible. Hence, we can modify these factors to get reverted to the normal epithelium. Like we will illustrate in further slides, the HPV infection can also cause cancer or can contribute in cause cancer. So, in short, cancer is a long-term process of evolution, and we can certainly detect in this stage, which is called screening for early detection. Now, a few slides about the epidemiology. Epidemiology means the status of the disease in the population. How many people are suffering? Why are they suffering? The incidence of head and neck cancers in India in 2020 was 10.3% of all the cancers, making it the second most common cancer after cancer of the breast. The 5-year prevalence is 21.77 per 1 lakh population. Just imagine, we are 1.2 billion plus people. The number of patients per year, the new patients are called incidence. The total number of patients, the old patient, treated patient, on follow-up patients, and the new patients together are called prevalence. And the new patients which are occurring per year is called incidence. The total number of patients at any point of time in our country would be tremendous. Point number 3 is showing this number of new cases of head and neck cancer 020, where 1,35,909. This appears to be much less maybe on the ground because we don't have a proper and perfect system of reporting of cancer incidence. The fourth point, that in India 60 to 80% of patients present with advanced disease. Head and neck cancer also occurs in the Western countries, the more developed countries, but they detect it early. Why? Because they have got a screening program, the awareness in the general population is more, they understand that there is a pre-malignant condition, so they report early. Hence, the prognosis, the cure rate, etc. in the Western country much better. In our country, 60 to 80% of patients present with advanced as compared to only 40% in the developed countries. Thus, head and neck squamous cell carcinomas in the developing world differ from those in the Western world in terms of age, site of disease, etiology, and also molecular biology. It is understandable that head and neck squamous cell cancer poses a major public health problem in India. This is highlighted. Major public health problem in India, as these have a lengthy latent period and needs dedicated infrastructure and human resource for treatment. The same thing in the pictorial form, as we see this 10.3%, this is breast. So it's overwhelming the number of patients. Now, what causes head and neck cancer? The causation is termed etiology. The usual time of diagnosis is after the age of 40 years. Exceptions are salivary gland, nasopharyngeal cancer, which may occur at younger age. Head and neck patients have an increased risk of developing a second primary tumor, both within the head and neck and elsewhere. Why this? Because of a phenomenon called field effect or field cancerization. Tobacco smoke or tobacco-chewed carcinogens, they not only affect locally, they affect all the mucosa of the upper airway digestive tract. The whole mucosa becomes unstable. You may have a primary cancer in left buccal mucosa, which can be treated and cured, and after 2 years, you may have a tonsillar cancer. This phenomena is called field cancerization. So, continuing with the causative agents, chewing tobacco. About 80% of our rural population is chewing tobacco. And a significant number of people are chewing bitter nut in various forms. Many people are using mishri. These are smokeless tobacco, which is causing the most important cancer burden of oral cavity cancers in our country. Second is, of course, smoking. Smoking has got not one, two, three, but hundreds of carcinogens. It not only affects locally the upper digestive tract, but also systemically. So smoking not only causes oral cavity cancers or head and neck cancers or lung cancer, also causes breast cancer, it also causes pancreatic cancer, it also causes urinary bladder cancer. Besides these two major etiological agents, contributory factors are plenty: poor orodental hygiene, owing to whatever, maybe lower social status, which is the norm in our country, and infections of the viral origin. Epstein-Barr virus, I'm sorry for the spelling mistake, it is EP, not EB, Epstein-Barr virus, and recently discovered HPV virus infection. Poor diet and occupational exposures of certain types, like asbestos mining people, or those people who are working in paint factories or working in nickel factories, chromium factories, they are at higher risk. Same thing reiterated again in pictorial form. A word about HPV, human papilloma virus, is a virus which has got multiple varieties. There are 16 odd types of papilloma virus variants. They are now known to play a role in developing squamous cell cancers of cervix in the female and head and neck cancers in both males and females, particularly of the oropharynx. Point to note is that there is usually a history of multiple sex partners, particularly orogenital sex, as HPV is spread through close contact. We will skip this slide about necros and come back to it later on. Before that, we will come to understand what a lymph node is. You are aware that cancer has got stages and that cancer spreads. Head and neck cancer arise the primary region, say for example tongue. They invade locally, go into the lymphatics and go to the regional lymph nodes. They also go into the capillaries, go into the bloodstream and tends to go to distant organs like lung. So why this lymph node? Because lymph node involvement in head and neck cancer decides whether the cancer is curable or whether it can be validated. A lymph node in the body is present in all parts of the body, especially the superficial ones, the axilla and the neck, the groin, and internally along the major blood vessels. Lymph is produced in the tissues after filtration in the capillaries of blood, and this is supplying nutrients to the tissue. Hence, there is an inflow and an outflow, and each lymph node has got its own artery and a vein. This tissue fluid is returned into the cardiovascular system by collection from all the areas, both outside and inside the abdomen, and they are conducted by means of a big thoracic duct. The other important thing to know is that the lymph nodes are located in a serial fashion, and the location of the lymph nodes is dependent upon which is the primary area. The major areas are submental, submandibular, upper jugulodigastric, middle jugulodigastric, lower jugulodigastric, and posterior triangular nodes. This is a simplistic description of lymph nodes, but as a cancer specialist, one has to go in much detail because the amount of involvement, the prognosis of the disease is completely dependent not only on the primary but most important by the involvement of the lymph nodes. This is a more detailed description of the lymph nodes. Besides knowing them by their regions as submental, submandibular, upper jugular, lower jugular, we have now numbered them. This is a very complex numbering system. We need not to talk that. Only as a background that if you are performing a surgery or if you are performing radical radiotherapy or curing the patient, the number of lymph nodes treated, either removed or irradiated, will be variable, and hence the comorbidity or the complication will be dependent upon that. This is just to illustrate that it is very important to know the extent of treatment by surgery or radiotherapy, because the complication will be dependent upon that. Once the cancer is diagnosed, it is supposed to be staged. Head and neck cancer is staged according to TNM classification given by AJCC, American Joint Committee on Cancer in the form of AJCC. TNM staging includes D staging, that is the primary tumor, N staging, that is the regional lymph metastasis, and M staging, meaning distant metastasis. A combination of T and M factor relates to the stage of the cancer. In general, the terminology is used, you must be familiar. T can be X, 1, 2, 3, or 4. TX indicates that the primary tumor cannot be assessed. It is present, but you can't measure it. T0 indicates there is no evidence of primary tumor. Then what were you looking for? If you have, for example, a lymph node in the neck, you will look for a primary site for a cavity. Lymph node has got cancer and you don't find anything inside, no primary tumor, then it is called T0. TIS, IS in small, is called in situ. Now onwards, T1, 2, 3, 4. Up to 2 centimeter, T1. 2 to 4 centimeters, T2. More than 4 centimeter, T3. T4 is what? T4 is that the tumor has gone besides its primary location. If it is in alveolus, it has gone in the bone. If it is in cheek, it has gone in masseter muscle. Neighboring structure involvement is T4, whatever the size. Naturally, the larger the size, the greater is the chance of involvement of the neighboring structures. So, Tx, T0, TIS, and T1, 2, 3, 4. These are the T stages. Now the N stages. N is the regional lymph nodes. The 5 group of lymph nodes I showed to you, submental, submandibular, etc. And the elaborate one of 10 or 12 lymph node stations. So whichever lymph node stations are involved, N is of 3 types. N0 is that there is no lymph node palpable. N1, 2, 3. N1 is size of the lymph node is 3 centimeters, say less than 3 centimeters. N2 means 3 to 6 centimeters. Or N3 means more than 6 centimeters. There are subdivisions of N2 and N3. We did not go into the detail. Only one thing I would like to point out, that left side of cancer will likely go into the left side of the neck nodes. That is true, but it is not so. The chances of bilateral involvement is always there. So N2 has divided ipsilateral and contralateral. If you have got contralateral involvement on top, then you have got a higher N stage. To summarize, N is N1, N2, and N3. N2 is of 3 types. A and B are ipsilateral, but the number of and 2C is contralateral. After the N staging, we have to consider the M. M is distant metastasis. Distant metastasis occurs because of blood-borne shedding of the cancer cells. And normally head and neck cancers go to lungs. It may go to any other organ like brain, bone, liver, kidneys, adrenals, etc. So thus you have got all these 3 factors T, N, and M measured, and then you make a stage grouping. This is stage grouping which starts from stage 1 to stage 4. Advanced head and neck cancers are those which are stage 3 onwards. Let's see what a stage 3 is. Any T1, 2, 3 with single less than 3 centimeter node N1 is stage 3. Anything more than that becomes stage 4. Stage 4 not means the presence of metastasis always. Presence of metastasis is stage 4, but without distant metastasis also head and neck cancers are staged 4. Stage 4, the heterogeneous group of advanced cancers. So, to sum up, head and neck cancers are classified by T and M classification given by AJCC. It is T factor, N factor, M factor. They are measured and there is a grouping made which is called the stage and the treatment plan is planned accordingly. We will skip these slides because pattern of spread means if a tongue is there, where will it go most likely? If a nasopharynx is there, where will it go most likely? Like a salivary gland tumor, adenoid cystic carcinoma, it has got a very interesting way of spreading. It is not only spreading through the lymphatics and the capillaries, leading to lymph node metastasis and distant organ metastasis, but also along the nerves. Any organ is supplied by nerves. The cancer cells, they spread along the nerves, which is called perineural invasion. So the pattern of spread is dependent on where the cancer has arisen first. We will skip this slide. But we will dwell upon this. The pattern of spread, as I said, is dependent on the site of origin of the tumor and the histopathology of the tumor. In histopathology, the tumor differentiation, the more the tumor looks like its parental tissue, the more differentiated it is. And the more it does not look like its parental tissue, the more de-differentiated it is. So there are three grades of differentiation called grade 1, 2, and 3. Tumor differentiation is one factor which decides lymph nodes will be involved or not. The primary size of the tumor, 2 centimeters or less, 2 se 4 se zyada. On that, the more the size, the more the chances of involvement of the lymph nodes. Then presence of vascular space invasion. This vascular space is what? In the cancerous tissue, apart from the cancerous parenchyma, I've got supportive tissue, which include capillaries and lymphatic spaces. Those together are called vascular space. If they are invaded more in slide on histopathology examination, the chances of lymphatic will be more. And fourth, naturally, the density of capillary lymphatics. Like tonsil is very, very rich in lymphatics. Tongue is very, very rich in lymphatics. So the density of capillary lymphatics is very. In any case, the squamous cell cancer in a cervical lymph, despite an extensive workup, the site of origin may remain undetermined. Such cases are called squamous cell cancer of unknown origin and is treated on a different line. Distant metastases are found most often in lung. As told before and now again, that risk of distant metastasis is related to end stage and the location of the involved nodes. The lower the nodes, the higher the chances of going to the lung. For example, the risk is less than 10% for N1 disease and rises to 30% for N3 disease. Now, there has been a little change. We have talked about PNM staging and we are talking about diagnosis now. So please don't mind. Diagnosis of any disease is on the standard lines. A careful and detailed history. Patient presents to you with a non-healing ulcer or a bleeding or pain in the side or TRISMUS or maybe symptoms due to distant metastasis like cough because of it. So symptoms. You take a detailed history, especially eliciting the of tobacco use, alcohol abuse, etc. And you examine the patient physically. systemic physical examination, and a detailed local examination. And you find about KPS. KPS, like the general condition of the patient, the physician uses this term, general condition of the patient, satisfactory, good, bad. Oncologists use a little more objective criteria of general performance status, which is called KPS. This term you must remember. KPS means Karnofsky, the name of gentleman devised this performance scale. It is an assessment of the overall functional impairment of the patient. It is used to compare effectiveness of different therapies and to assess how the patient will actually fare after the treatment. This is depicted in the next slide. And it simply says, the more the KPS, the better it is. 100 KPS is good, healthy, no symptoms, no sign of disease. And 20 is very ill patient, which requires admission and supportive care and treatment as an emergency. 70, usually the cutoff for good prognosis and poor prognosis patients. 70. So what is 70? A patient of cancer who can care for own self within the activities, but he is not capable of normal activity or work. KPS is graded in a scale of 10, 198 till 20. 0 means death. KPS thus is part of general examination and guides all the treatments and the prognosis of the patient. After history taking and physical examination, both systemic and local, we go for investigations. Most important investigations are imaging investigations. Imaging investigations will not go into details of it. They can plain X-ray, they can be computed tomography scans, or they can be MRI scans, they can be PET scan. A combination of X-rays or CTs or MRIs gives the exact location and extent of local tumor as well as the distant metastasis, so that you can make a definite plan of treatment and prognosticate outcome. But how do you confirm whether tumor or the ulcer which is there is actually a cancer? That is what the confirmatory test, and that is always done on the basis of a biopsy. Biopsy means either taking a tissue from the tumor or taking out cells from the tumor and examining it under the microscope by hematoxylin staining and further test depending on the cancer. One word about FNAC. FNAC is an OPD procedure by means of which you aspirate by means of a 22 gauge needle on a normal hypodermic syringe, aspirate cells from the node or the primary tumor, spread it out on a slide and see under the microscope. So you see cells. Similarly, you can see cells by exfoliation cytology. You can simply press a slide onto the tumor and try to see. Similarly, there are many other ways to find tissues or cells from the tumor and examine it histopathologically so that you can confirm the diagnosis. One word about the true cut biopsy. I think true cut biopsy and taking biopsy by means of true cut biopsy needle should be taught to everyone at a primary health center under the guidance of maybe a graduate. But one should know this is one of the most easy way of getting an early diagnosis, even in the periphery. If only you know how to make true cut biopsy neatly. See this next slide. Not much different from the hypodermic syringe. There is one plunger and one outer shell which goes into the tumor, and similarly by pushing the plunger take out tissue and put it in formalin or normal saline bottle and send it to the laboratory. This is one of the easiest way of collecting, but it should be done under guidance of a doctor, but it can be performed and it should be learned by all the paramedical staff. I am sure that this can be done. This will go a long way diagnosing a cancer early. So we have diagnosed cancer, we have staged the cancer, and we have made up our mind to treat the patient. Now, so many factors which will decide whether the treatment will be curative or palliative. These are the two things to understand at the outset by everybody involved in management of the patient. Curative means attempt to cure the patient by using your treatment modality, either surgery or radiotherapy or chemotherapy or a combination of both. There is a fair chance that you will be able to remove the cancer, control the cancer, and follow up the patient lifelong. He may have some side effects, but he will not die of cancer. Such attempt of treatment is called curative treatment. But it depends upon the stage of the tumor. Earlier the stage, the better the chances of cure. It depends upon the performance status of the patient. 70 plus performance status will fare better, and it depends upon many other factors. So, in the beginning, a decision whether I can cure the patient is paramount. Even advanced cancers can be cured. T3, T4 lesions can also be cured. If the decision at the beginning is that the combination of factors is such that either the patient cannot take on the treatment intensity, then the treatment palliative. Palliative means relief of symptoms and trying to prolong the life. So the terminology curative and palliative must be very clear in it. Now, adjuvant and neoadjuvant, I will tell you in the next slide. The treatment approach is always multimodality, in which head and neck surgeons, radiation oncologists, medical oncologists, radiologists, plastic surgeons, pathologists, dentists, speech and swallowing therapists, physical therapists like yourselves, and social workers, all are involved. We were going to decide curative and palliative, and we were going to decide adjuvant. All those have to be decided by the board members, which includes all of them ideally. There are three treatment modalities. Most importantly, radiotherapy, surgery, and chemotherapy. You can combine all these or two of them. When you are sure that surgery will be curative and addition of radiotherapy may be beneficial, then you can add radiotherapy either before surgery or after the operation. When you add it before surgery, it is called preoperative or neoadjuvant. When you give radiotherapy after surgery, then you call it postoperative or adjuvant. Does that make those two words clear? Adjuvant and neoadjuvant? These terms are important and because they give you the order in which treatment has been given and why they have been given. So, to sum up, there are three modes, primary modes of curative and palliative treatment: radiotherapy, surgery, and chemotherapy. Many a time in advanced head and neck cancers, the combination of more than one. There are advantages of surgery and advantages of radiotherapy. We'll not go in details of that, but both have got disadvantages also. Yes, we will dwell on this slide that a combined modality approach is the best approach to tackle advanced head and neck cancers because the best chance of cure is the first chance. Combined modality therapy may be avoided for lesions with a high cure rate by one modality. For example, if you have got a buccal mucosa lesion 2 centimeter in size, you operate it and don't give anything else, or you give radiation by interstitial brachytherapy and don't do the surgery. So single modality is also curative depending upon the stage of the disease, and when you use single modality, you avoid the complication of combining more than one modality, surgery and radiotherapy and chemotherapy. But by and large, in advanced head and neck cancers, surgery and radiotherapy plus minus chemotherapy is required even for palliation. The last point of the slide, salvage. Salvage therapy means that you have attempted curative treatment, you have done the surgery, you have done the radiotherapy, you have started following up the patient is alive and well with some comorbidity. He has got dry mouth, but he is doing well, surviving. He has gone into chronic phase of survival, some morbidity, but he is coming on follow-up. But over a period of 2 to 3, 4 years, you find that the disease has come back again. When the disease recurs, that is comes back again, then can you cure it? Yes, you can cure it depending upon multiple factors mentioned before. Such a treatment is called salvage therapy. Supportive management. Head and neck cancers cause a variety of symptoms which drastically reduces quality of life functions. Imagine a patient of a tongue cancer who is unable to speak properly, swallow properly, sleep properly, and the likelihood of him losing the tongue and losing the movement because of treatment is high. So you require constant supportive measures, not even waiting for the diagnosis to come, but prior to that, that is motivation first, social support first, and many other support systems. What I mean to say is that you need not wait for the supportive measures to start after a particular point of time. It should start at the earliest. Providing them symptomatic relief before initiating or during the therapy improves their quality of life and also provides better compliance. Difficulty in swallowing and reduced mouth opening can be taken care of by establishing feeding support like a nasogastric tube or a RISE tube version. Severe neck swelling due to lymphadenopathy or obstruction of the airway tract by the tumor can cause respiratory distress or a stridor and may require a temporary tracheostomy. All these factors, they may land the patient in an emergent condition which a sudden deterioration of respiration may require a tracheostomy. A sudden blockage of the pipe requires a feeding jejunostomy or a RISE version. And there is a constant requirement of making pain. All these are supporting measures. It is a comprehensive field supporting measures which involves physiotherapists to a large extent. This is an illustration of nasogastric tube. In fact, a lot of head and neck patients are maintained nutritionally by the use of a nasogastric tube. Every person, including the home members, who is a caregiver, irrespective of his specialty, doctor, nurse, physiotherapist, must know care of a nasogastric tube and how to maintain the nutrition of the patient at home. Similarly, a patient of head and neck cancer who is tracheostomized normally will not revert back to closure of the. There are conditions which can close the tracheostome and the patient can breathe normally. But in advanced head and neck cancer, because of the chances of recurrence, you may not be able to close the tracheostome, so you have to be an expert in maintaining the tracheostomy tube. One of the most important factors for maintaining the tracheostomy tube, type of tube, knowing the different sizes of the tube, proper humidification, proper cleaning and hygiene, because such patients are high risk of pneumonia and aspiration. Sorry. As we were talking about the different modes of treatment, there are surgery in head and neck cancers and radiotherapy added on it, which result in lots of morbidity. Let's know a little about the different types of surgery. Surgery can be done for cure also, or palliation. First term is wide local excision. Wide local excision is removal of the primary tumor, normally T1, 2 cm. Wide local excision means removing the tumor along with a healthy tissue margin. The amount of tissue margin will be dependent on the surgical skills of the operator as well as on site. Radical excision of the primary tumor in advanced stages. If it's T2, T3, tongue for example, tongue has to be sacrificed. It may be a partial glossectomy or a total glossectomy with a reconstruction of the tongue, maybe or maybe. Such a big ablative surgery for the treatment of the primary tumor. And along with this, you do neck dissections of various types. Neck dissections, removing the lymph node involved of the ipsilateral as well as the contralateral side. Some standard names of some surgeries, as we were talking about, a T1, T2 cancer of tongue will require a partial glossectomy, ipsilateral neck dissection, contralateral supraomohyoid neck dissection. It will require primary closure of the wound by various types of flap surgeries like free flaps, local flaps, rotation flap, myocutaneous flaps, osteomyocutaneous flaps, etc. These are some pictures of the ablative surgeries. Commando operation you might have heard, which requires the complete excision along with the margin of the organ, or like hemimandibulectomy with reconstruction by a fibular graft radical section. This is a morbid surgery, but it cures many number of patients. Surgery followed by reconstruction has many acute and chronic patients. Similarly, radiotherapy as a treatment upfront or post-operative also causes morbidities. Acute complications are there, like wound infection, chyle leak, flap necrosis, donor site morbidity. Medical problems also like cardiac, deep vein thrombosis, etc. And chronic complications, which should matter to us more, they include shoulder pain or dysfunction, neck stiffness, edema, trismus, loss of motor innervation of sternocleidomastoid and trapezius muscles cause of the surgery or radiotherapy, then skin complications, which include cervical contracture, pain and thickening, edema of the tissue. Other complications which will be shown in the next slides. Sequelae of the disease and the treatment interferes with patient's quality of life. Rehabilitation in relation to cancer can be preventive, restorative, supportive, and palliative. Physiotherapy plays a major role in rehabilitation of academic cancer survivors. It prevents and treats multiple complications arisen because of treatment. It helps cancer survivors in restoring them physically, emotionally, socially. World Congress for Physical Therapy (WCPT) defines a physiotherapist as providing services to people and populations to develop, maintain, and restore maximum movement function. The problems which you will be dealing with in head and neck cancer management is primarily shoulder pain and weakness, trismus and temporomandibular joint dysfunction, lymphedema, swallowing difficulty, respiratory complications. Shoulder pain and weakness is your reserve. Neck dissection is associated with this because of loss of function. It can be prevented through assisted range of movement exercises, strengthening of elevators, neuromuscular retraining, preservation of trapezius muscle electrical stimulation, providing many types of shoulder support, etc. Trismus and temporomandibular joint dysfunction, the very common complication after treatment, mouth opening exercises, use of jaw stretches by increasing mouth opening, diet modification, use of moist heat, relax the muscles, dynamic splinting. These are the few things which you have to offer. Lymphedema similarly will be managed by conservative measures. Swallowing difficulty will require diet modification and motivation, maintaining tongue strength and mobility, laryngeal muscle exercises, the spatial Mendelssohn maneuver. Respiratory complications may be prevented by incentive spirometry even at the beginning of treatment, and post-treatment this should be continued. Cervical contracture requires active and active assisted range of movement in all planes of neck motion. Additional stretch during end range by exerting pressure with the contralateral hand. Postural modifications with the help of visual aids. Self-massage to augment the efficacy of ROM activities. Compression garments. In conclusion, once cancer patient is cured by primary treatment modality, most patients experience some physical impairment resulting in a physical disability. This aspect of treatment is most neglected among all treating physicians, especially in third world countries. It is our responsibility to ensure that all cancer patients regain maximum function, making them to return to all former duties. The exact functional deficits should be identified and proper rehabilitation should be started immediately. Preventive aspects of rehabilitation should be taught to the patient long before the patient develops symptoms. Multidisciplinary rehabilitation should be made an integral part of the total management of the head and neck cancer, justifying the physiotherapist's crucial role in the holistic management. Thank you.